Hi, it's Dr. Bill Harris. Welcome back to Epigenetic Orthodontics and the DNA online certification course. This segment is on laser-assisted lingual frenectomy for people that are tongue-tied or tongue-restricted. So as we've learned previously, the tongue is the engine that pushes against the maxilla, which makes that maxilla as wide as your tongue. Your tongue is always supposed to be resting on the roof of the mouth. If you're tongue-tied or tongue-restricted, you physically can't get your tongue up to the roof of the mouth with enough strength to develop the maxilla. In the hospitals, they're supposed to check for tongue tie when the babies are born, and they would typically you would do surgical release, because the first time I usually see a patient is when they're 1 year old. The rule I use in my office is first tooth, first checkup. But now actually, if I have a patient who is expecting, I'm asking them to bring their baby in when they're just born. And the youngest I've done a lingual frenectomy on is a 2-week-old baby. So if they miss it in the hospital, then if you see it, I think that you should do the surgery for the patient. Now, in Alberta, we're licensed to do anything up to the oral pharynx, which means we can legally do lingual frenectomies, but we can't legally take tonsils out. Here's a patient that's got a big tongue. I would say that's longer than normal. He does not need a lingual frenectomy. This patient does need a lingual frenectomy. So he's a 49-year-old gentleman, came in and we checked his tongue and he's severely tongue-tied. The classic tongue tie, the tongue forming a heart shape. When you open wide and you lift your tongue up, you should be able to touch the tip of your tongue to the roof of your mouth without closing your jaw. If you physically can't get your tongue past your lip, that's the classic definition of tongue tie. Tongue restricted means you can lift your tongue up, but you can't lift it all the way up. So this patient was severely tongue-tied. So I said, you need a tongue clip. And he went along with it. So we froze him. We used our laser and it released the tongue, and that's how much you could stick it out immediately after surgery. He's still tongue restricted. He's a severe tongue tie. Now, the tongue tie that I'm talking about is anterior tongue tie. Sometimes the fibers are posteriorly attached, and in that case you're going to need to have an oral surgeon or an ears, nose, and throat or a plastic surgeon to actually release the posterior tongue tie. Having said that, just releasing the anterior tongue tie helps a lot of people. This is a patient that's tongue restricted. Now his frenum is very thin. Now normally we have, the way it forms is the floor of the mouth and the tongue are one ball of cells, embryologically speaking, and then the cells die off in between to separate the tongue. And if they don't die off enough, then you're tongue restricted or tongue tied, and that's a genetic component. So that's genetically inherited. So look for that in families. If you have a sibling, if you have a parent that's got tongue tied, look at the children too if you can. So a tongue that's lingually tied like that, to me, is very simple with the laser. So we freeze it with some TAC-20. I have a soft tissue laser. We put it at 1.2, which is cutting wavelength. We initiate the tip on blue bite registration material. Then I grab the tongue with a cotton gauze and I stretch it as much as I can. Sometimes they'll start to break just stretching the tongue. In this case, we used our laser and did a little swipe. It cut. We did a little swipe again, cut some more, swipe again, cut some more. If you see that big lingual vein, you do not want to cut into that. Stay away from the lingual vein. And that's what it looked like at the completion of the surgery. With the laser, it doesn't bleed much. And that's how much he could lift his tongue up, and that's how much he could stick his tongue immediately after surgery. So now, in conjunction with the laser surgery, if your tongue does not know how to swallow properly, normal function is the tongue on the roof of the mouth. If the tongue has been physically held down by that lingual frenum, that patient may need oral myology. Oral myology is exercises for the tongue to help retrain the tongue. And I sent my staff to a program by Joy Moeller and Barbara Green. They're oral myologists from California, and we do oral myology training in the office. So to recap, we want to do oral myology, we want to release the tongue, and then we want to retrain the tongue, and then we want to make the roof of the mouth as big as the tongue. We want to do the job that the tongue hasn't been doing. And that's where the DNA appliance comes into play. We're going to use the DNA appliance to actually make the roof of the mouth as wide as the tongue. 38 for Caucasians, 40 for African or Asians, and retrain the tongue. Now this tongue is tied, and it's a severe tie, very thick at the base. It's going to improve it, but this was what I would call a posterior tongue tie. That's how much the patient can stick their tongue out. Previously they couldn't get it past the edge of their lip. She has a huge tongue trapped in a little jaw. So she has a DNA appliance on. We're developing her jaw. Unfortunately for her, she was a 4 bicuspid extraction case, which in my opinion makes it much more difficult. And a lot of the problem is because she was tongue-tied. It was never diagnosed if it was never picked up. This is 1 week post-surgery. Can you see how thick that tissue is on there? Very thick. Probably should have a posterior tongue tie also release. This is another patient that has a tongue tie. He's a cleft lip and palate. He's tongue restricted. See those large veins under the tongue? You don't want to put your laser into those. You just want to release the frenum. And that's what he can do after we released his tongue. He also had big tonsils, and there's his tongue. This is to remind us oral myology is really important to help retrain the tongue. Not everybody's going to have a tongue like that, but we want to be normal for our age, normal for our function, which is a tongue that's free to move and work properly and push up in the roof of the mouth when you swallow. In fact, post-orthodontic treatment, the best retainer is a properly functioning tongue. So I'd really encourage you to check every patient for tongue tie and tongue restriction. Don't be afraid to do the laser surgery on them. If you don't have a laser, you could use a scalpel or even a pair of scissors. It will benefit the patients. Good luck.